So good afternoon. My name is Sue Grinnell, and I am very excited to have Dr. Caroline Fichtenberg with us today. And Caroline is the Managing Director of SIREN, which is the Social Intervention Research. Can I ask folks to put yourselves on mute while you're joining? Just so we can minimize the noise. Great, thanks so much. And she is incredible. I'm excited for you to hear what she's been learning. I think really kind of in this journey to hear about different screening tools related to social determinants of health and just kind of what she's finding. And these tools, right, are being used to identify social needs as well as interventions in clinical settings. So I think she's going to highlight those and really speak to opportunities around those, and particularly for your work in the accountable communities for health. So with that, I'm going to turn it over to Caroline. So thanks.
Thank you, Sue. It's so great to be speaking to all of you. I'm curious if I could ask folks, since we're a relatively small group on the line, if we could just go around and do a brief round of introductions. That way I kind of have a better sense of who you all are as I'm going through. So you've just heard about myself, and I don't know if we can go kind of in order of the folks that are here on the screen. I see Martin Love.
Hi, I'm Martin Love. I'm the CEO of Ensign, the North Coast Health Improvement Information Network.
Great. And then I see someone who's this is Gilly, or G-I-L-E-E.
Hi, my name is Ginger Lee. Sorry that you see my inbox. I have to turn this around. But I'm with the City of Long Beach Department of Health and Human Services.
Great. And Debbie Kent.
Hi, I'm Debbie Odokamp with the Health Education Council. And
where are you?
UCH. West Sacramento.
Sacramento, great, awesome. Catherine.
Hi, Catherine Johnson with PHI.
Great. Larry.
Larry Gruder with Community Translational Research Institute, and we're the Riverside CACHI site.
Great. Patty?
Hi, I'm Patty Torres. I'm the project manager for Humboldt County's ACH site, which is focused on substance use.
Wonderful. Amy?
Hi, yes, I'm Amy Kuster. I'm also with Citri with Larry, and I'm the program manager.
Wonderful. Nice to see your face for a moment.
Thank you.
We have G. Roberson.
Sorry, I was on mute. Gina Robertson. So she's the, I don't think she can speak. Well, she can speak.
You know what, Sue? Can you
oh,
hear
you are.
I got a new computer, so this is new. So I'm Gina Roberson with the West Sac ACH at the Health Education Council.
Wonderful. And it looks like we skipped over Heather. Heather, if you don't mind introducing yourself. You can unmute yourself, or you will need to unmute yourself to be able to introduce yourself.
Sorry, good first step. I'm so sorry. I'm in a very noisy setting, so I apologize for that. My name is Heather Hayes. I'm the Associate Director at the LAC USC Medical Center Foundation, and we are one of the CACHI Accelerator sites located in Boyle Heights, which is in East Los Angeles. And we are focusing our collaborative of the Wellness Center around the issue of trauma-informed care.
Great.
Is there anything
well, thank you so much. No, that was it. We just wanted to get a sense of who was on the call.
Fantastic. Thank you.
Thank you so much. Great. So I'm going to be talking to you today about the work that healthcare organizations have been doing around social determinants of health, increasingly doing around social determinants of health, and the opportunities that that work presents for community health improvement activities, multisectoral community health improvement activities. So as Sue mentioned, I'm at the University of California, San Francisco, and I work for a project that is, let's see, there we go, that I'm going to just summarize briefly. So the initiative is called the Social Interventions Research and Evaluation Network. And we are an initiative that is housed at the University of California, San Francisco, but that works nationally. Our mission is to catalyze and disseminate high-quality research that advances efforts to address social needs in healthcare settings. So a few different things here. We're focused on kind of advancing the development of research and also on disseminating it, and research that's specifically focused on the ways in which healthcare organizations and individuals working in healthcare organizations can better address patients' social needs as part of the work that is done in healthcare settings. So our work fits kind of into 3 buckets: catalyzing high quality research, which we do through grant funding and through connecting researchers and helping to identify research gaps. We disseminate research findings and tools. And so on our website, we have an evidence library that has where we've tried to collect in one place all of the peer-reviewed and also gray literature that is being published in this area, specifically of interventions in healthcare settings to address social needs. So it's a great resource if ever you're looking for kind of what's been published on a particular topic. Highly recommend going to our website and looking at our evidence library. We also have some pages that I'll show you later on in the presentation that has more information around screening tools and things like that. And then we also provide evaluation, research, and analytics consultation up to 2 hours to any organization that wants to help thinking about how to evaluate a social needs intervention. So why is it that Siren exists? Siren exists primarily because there's been this huge surge in interest in social determinants of health in the healthcare sector. And I'm going to share this one slide to help encapsulate kind of why the healthcare sector has become so interested in social determinants. Well, really 2 slides to talk about that. This first slide is a really interesting one, and it's a graph of life expectancy on the vertical axis, plotted against health expenditure per capita, which each line representing a country and representing a country over time. So the line in red is the US, and you can see it goes from 1970 to 2014. And the other lines represent a number of other industrialized countries. And what this graph shows is that basically the relationship between life expectancy and health expenditures in the US has really diverged compared to that relationship in these other industrialized peer countries. Starting probably in the mid-1980s, you can see we start veering off to the right in this image, which means that our life expectancy isn't growing as quickly as other countries, and at the same time, we're spending more money per capita on healthcare. So I think this graph is kind of one of the ways of illustrating that we in the US spend way more on health and get less good results than other peer countries. And it's something that a lot of us know about, and a lot of efforts are focused on trying to figure out why that is and how to reverse this trend. One of the areas that has gotten a lot of interest in this area is the idea of social determinants of health, and the realization and accumulating evidence over the past few decades that highlight all of the different things that go into our health, and in particular highlight the relatively minor role that healthcare plays in shaping our health compared to things like health behaviors, our physical environment, and socioeconomic factors. So as research has accumulated documenting the ways in which these social determinants of health, socioeconomic factors, health behaviors, and other things affect our health, there has been this really growth and interest over the past, I would say, 5 years, spurred in large part by new incentives in the healthcare system that were put in place by the Affordable Care Act that have really created a surge of interest in the healthcare sector in social determinants of health. So this slide shows a few different headlines, recent headlines that talk about how social determinants of health are gaining traction as United Healthcare and Intermountain build new programs. You know, the CEO company, often called the future of health care, explains why health insurers want to cover your rent. So thinking about housing. Humana targets social determinants of health, improves outcomes in 2 cities. Hospitals target nutrition, other social needs to boost health. So there's just been this explosion of interest in social determinants of health, and in particular in basic needs aspects of social determinants in the healthcare sector over the past few years. And what form that interest has taken, and I know I have some organizations on the call that are probably engaged in this kind of work, but the form that we've seen it take at Siren is something that I'll call social needs care. And it's this idea that in clinical encounters, patients are being screened for unmet social needs and then referred to either external resources or internal resources, or sometimes provided kind of extensive navigation services with community health workers, social workers, patient navigators to access resources to help address those needs. So that's taking sometimes, as I mentioned, the form of referral to external resources such as food banks or benefit assistance programs. Sometimes health systems are developing in-house resources, so for example, food pharmacies or food bank drop-offs on particular days, medical legal partnerships where legal services are available on site to address any legal issues that might come up. And at the same time, a number of organizations are really turning to community health workers, social workers, patient navigators, other types of staff to help provide support for patients that might need it to access external resources or internal resources to address these unmet needs. And I want to stop it for a moment and just kind of talk about the thinking that's behind this. This is a kind of meant to represent, I think, what folks in the healthcare sector are trying to do here. So because social needs, unmet social needs, impact health negatively, the idea is that by connecting people to resources, we can reduce social needs, thereby improving health, which would have two impacts: reducing health inequities, because most of these services are being targeted to people with poor health and often with a lot of socioeconomic barriers to health. So that would reduce potentially socioeconomically driven health inequities. And then at the same time, there's a hope that this will reduce unnecessary utilization and reduce healthcare costs. What is particularly exciting to me about this work is that I feel like it presents kind of another way of going upstream. So I think that you are all probably familiar with this notion of downstream versus upstream, the metaphor of, rather than pulling people out of the water, saving them at the very last minute, you would go upstream and find out why people are falling in the water in the first place and prevent them from falling in the water in the first place. So this metaphor is really about this idea of, instead of treating people once they're sick, preventing illness. So it's kind of a fundamental metaphor in public health and population health. In the public health world, a lot of that upstream focus has led to folks moving away from individual level types of interventions and towards population interventions, so policy, systems, and environmental change type interventions. But a lot of that work, at least from my experience when I was working in a health department in the past and the American Public Health Association, a lot of that still focused very much on kind of policy and systems changes focused on health behaviors. So how do we make policy and systems change that can make the healthy choice the easy choice? How do we build more bike lanes and develop complete streets? How do we increase the availability of healthy foods? But how do we create disincentives for smoking and tobacco laws that protect people from secondhand smoke? But it still is very focused on health behaviors. And I think what's very interesting about the focus on social determinants of health in the healthcare sector is that it's moving away from health behaviors and really focusing on basic needs: food, shelter, transportation, jobs, helping people address kind of some of the fundamental needs in Maslow's hierarchy of needs, which really gets to a lot of the root causes of many health conditions. So I think it's a really interesting and fundamental shift in thinking about social needs that is very exciting. So I'm going to talk now a little bit about kind of some of the evidence about the impacts of these interventions, since that's really what what we focus on here at Siren. And obviously, I think before moving in any one direction, you want to know, do these interventions actually work? One of the first studies on this was a study published in 2015, or on these particular interventions specifically that are these broad screening interventions and referral to external services. It was done in Boston. And this was a study found that systematically screening and referring for social needs services during well child care visits increased families' receipt of community services. So an early indication that there's something that if you do refer, you may be increasing access to these services. Then another study looked at the health leads intervention in the Boston area, and this is an intervention where volunteers, often college students, are put in clinical settings and are available as kind of a resource for anybody to, any provider or member of the care team. If they identify that a patient needs help connecting with a resource, they can see somebody right there. So it's a form of navigation to services, and help these volunteers help people fill out applications, help them follow up on particular issues, et cetera. And this evaluation found that referring to services to address unmet basic resource needs in primary care, and this was in adults, was associated with modest improvements in blood pressure and lipid levels. So interesting direct tie to some biomedical measures of health, which honestly, you know, coming at this as someone who had been in the healthcare sector, I have to say that I was initially skeptical about the impact of these interventions, because I figured really how much help can it do to just help connect people with resources? I would imagine most people probably know that these resources are out there, et cetera. But this body of literature is finding, in fact, that there is an impact to doing this. And then this was a study that came out a couple of years ago by my colleague and Siren director, Laura Gottlieb, here at UCSF, that found in a randomized control trial that in-person resource navigation for pediatric patients in primary care and urgent care settings actually reduced reported social and economic needs and also improved caregiver-reported child health within 4 months. There's been newer research now that has also looked at a different form of this kind of intervention, which was a call center-based social needs referral program, and actually looked at costs. And this study found that the social services referral program reduced expenditures if social needs was met. Now, this was not a randomized controlled trial, so there are definitely, this result I would take somewhat with a grain of salt, but it's encouraging looking in the right direction. And then there's been, and I apologize, I'm realizing my little boxes at the top are not following the necessarily the topic of the research. Apologize for that, but the results are still the same. So for this particular study, also a recent study, looked specifically at meal programs and found that meal programs, the distribution of meals, and this included both medically tailored meals and non-medically tailored meals, were associated with fewer emergency department visits and lower medical spending. So encouraging results for nutrition interventions specifically. If you're interested in looking more at evidence, on the slide here is a screenshot from our evidence library on our website, which is sirennetwork.ucsf.edu. At the bottom of the screen, you can see the URL. And so you can look here in our resource library for research based on the social determinant of health, or based on a particular outcome that you're interested in. For example, if you're specifically interested in cost or utilization outcomes, you can look at studies that have looked at those. And we now have over 500 elements in the resource library, so definitely recommend checking it out when you're looking for evidence on this topic. Coming back at this, obviously these kind of interventions only work if there are sufficient services in the community to address these needs. So that is where my kind of, another piece of my big skepticism about these interventions is that is great to connect people, try to connect people to address issues like food insecurity and housing, et cetera. But we do not in this country have a very, very strong safety net, especially around issues of housing. It's very hard to have resources to point people to, but even across a range of needs, there aren't always resources available. So this is where I think that there are incredible opportunities for multi-sector collaboration to be working hand in hand with health systems that are engaging in social needs care and interested in this approach to help ensure that services are available in the community to address these basic needs. So I have up on this graph kind of just some initial thoughts around engagement opportunities. So one is around using data about unmet social needs to identify and highlight gaps in community resources. And I'm going to touch a little bit more on that in the rest of my slides. But these health systems, in the work that they're doing, the first step being the screening for unmet social needs, they're collecting a lot of data about these social needs. And this data can often be helpful for in community efforts to highlight gaps in resources and help galvanize energy to help address them and resources to help address them. There are lots of opportunities as well to work with health systems to create more coordinated set of basic needs resources. So health systems are now seeing potentially a return on investment because of value-based care opportunities. They're seeing potentially a return on investment for investments in addressing these basic needs that then could lead to health improvements and improvements in quality of care. So quality metrics could become better. It's very hard to help patients control diabetes if they're food insecure. So health systems that are being tracked for quality metrics related to diabetes control have an incentive potentially to invest in helping to address food insecurity at the community level. So it's a great opportunity there to engage a health system in addressing food insecurity. Housing is another area where we're seeing a lot of interest in health systems, and transportation as well. And so this goes also to the third bullet here, engaging health systems as funders of basic needs community investments. We're seeing a number of larger health systems, health insurers in particular, also investing in housing, transportation, types of interventions, with the thinking being that this will improve health and return on investment for them. So that's also a great opportunity for partnering with health systems. And then another one, I think, is engaging providers and health systems as advocates for policy change. So I was talking recently to a health system in San Diego that had been working with a food coalition there, anti-hunger coalition. And what the anti-hunger coalition really, really wanted out of the health system is that they be vocal advocates in the community on hunger issues, that the bully pulpit voice of these health systems they felt could really be meaningful for policy change locally. So it doesn't just have to be about financial investment. There's also just the investing the voice of a community resource like a health system can be very helpful for community change initiatives. I'm going to transition now to talking a little bit more about the data and the opportunities around data, and highlighting the data that's being collected in health systems. Here I have a summary of some of the categories that are being focused on in health systems around meeting unmet needs. Food insecurity, housing, and transportation are kind of the three main ones, I would say, that we see health systems focusing on, with food insecurity really being kind of oftentimes the first one. If health systems are just starting out in this work, they may say, okay, let's start with food and see what we can do, both because food has such a clear direct link to health, and because there are often very clear resources that are available to connect patients to around food, whether it's food banks or helping people connect with SNAP and things like that. And then housing is another one where we're seeing a lot of interest because of the high cost associated oftentimes with people who are homeless or precariously housed, and so the potential for return on investment. And then transportation is being looked at because also there's a direct return on investment particularly for medical transportation to medical appointments, so non-emergency medical transportation, where you can potentially reduce no-shows, which is an immediate win And we're seeing a number of health systems investing in this, of health insurers investing in this, as well as companies springing up to help fill this, this market gap. But then we do also see interest in financial security, education, employment. There are some programs working on employment, connecting people to childcare, safety issues, and highlighting need for social support. This slide highlights some of the tools that are used in this space, and I'm going to go into these in a little bit more detail. So the Accountable Health Communities screening tool is one of the ones that is getting a lot of interest these days, as well as Prepare, which was a tool developed for community health centers. So let me just highlight those a little bit, and then but there are a bunch of other ones. The Accountable Health Communities tool was developed by the Center for Medicare and Medicaid Innovation, and as part of their Accountable Health Communities model program. So not the ACH, but the AHC. And there are 31 Accountable Health Communities model sites around the country, none in California. They were funded starting about a year ago to test out this idea of screening for unmet social needs and connecting people to resources to address those needs. And this screening tool was developed for use in those sites. It's the only screening tool that's been developed by a federal agency. So it's attracting a fair amount of attention for that. It's also, there's 10 required questions for the model sites to use, covering 5 topics: food insecurity, housing instability, transportation and utility needs, and interpersonal safety. And so it's a pretty short screening tool. And then there's another 16 optional questions on other topics. Earlier this year, it was adopted by the American Academy of Family Physicians. It's kind of the tool that they recommended. So if you've got any interest in kind of looking at tools, this is one definitely to check out. The other one that is used fairly frequently is the Prepare tool, P-R-A-P-A-R-E. And this was developed by the National Association of Community Health Centers with a number of partners, with a focus specifically on collecting information in community health centers. It's longer than the AHC tool. It's got about 21 questions. It does include some things that the community health centers have to capture anyway as part of their requirements for some of their funding sources from HRSA. So veteran status and migrant status are things they have to collect, are required to collect. But then it includes also food insecurity, housing, employment, transportation, and a number of the other things that are typically looked at. And there's a number of resources about Prepare on the NAC website, including templates for EHR integration and recommendations about how to institute screening, et cetera. So that's also a place for a lot of resources. I want to highlight that there are a lot of different tools, and they measure a number of different things. So this table shows vertically a number of tools. So you see the AHC tool all the way on the left, and Prepare is kind of in the middle towards the right, but then these other tools. Health Leads as a tool, Health Begins, which is an organization that does a lot of work in this area, also has developed a tool. And then there's a number of other tools, and on the rows here represent different categories of domains of need. And as you can see, different tools cover different domains. The gray parts are where that particular tool has a question about that domain. So there's a fair amount of variability, although there are also some topics that are more commonly looked at. So food insecurity is on nearly all of these, and intimate partner violence is also pretty much on all of these tools. Housing is pretty frequently asked about as well. So it kind of gives you a sense of the variety, but also which topics are looked at a lot. And we have a version of this table on our website if you're interested in looking more deeply at any of these screening tools. This is a screenshot from our website. We have all of these tools and which topics they cover, and then you can actually go and look for particular questions kind of for each tool. How do they ask the question, so you can compare across tools. That is where I think I wanted to end. I'm bringing back up this slide about what's happening in the healthcare sector to just kind of recap that there is a lot of really exciting new things happening in the healthcare sector around basic needs. which is this kind of way of going upstream, really to root causes of health, that I think present a number of opportunities for multi-sector collaborations that want to improve community health, both around data as well as around interventions. Want to just encourage all of you to be thinking about how to connect with those kind of efforts in your community, and want to end there and open it up to questions.
Thanks, Caroline. That was amazing. One thing, folks, I am recording this, so I'm going to post the recording and the slides. And I think, you mentioned a number of links. So I think, on the website, I'll just make sure we have the links to those. So even though they're embedded, just so people will have that. So thank you. So questions?
Thoughts, comments?
I'll start. I think two things. One thing is I was just wanted to highlight the piece that you talked about around like the unmet social needs and the data that's being collected in those sites and how maybe that's being untapped. I think, Caroline, before you and I talked about this notion of community health assessments and whether or not, and I think a lot of the sites that are on are actually involved in that right now because of the community health needs assessment piece that's happening with the nonprofit hospitals, whether or not they're actually even thinking about going to hospital or to providers that might be capturing this, because that's like an incredible source of data, right? Like what they're actually seeing. So I don't know if you have anything to.
And I don't know. I don't know the answer to that. Does anybody on the call have any experience with that? Are any of you seeing these data make their way into community health needs assessments?
I know Sacramento, I'm just looking at the sites where I know they're kind of in it right now. I don't know, Gina, if you're aware. I know Fresno, but it's just an interesting point, right? So
yeah. And there are challenges with it, obviously. I mean, it's not population-based data, right? Yeah. It's going to be, and the screening is not always systematic. So sometimes particular populations are targeted. So there are obviously issues with, it needs to be put in context. But I have heard repeatedly when talking to leaders or providers or staff in healthcare settings who will say, oh, well, we knew that our patients had needs. We kind of knew. But getting the actual data directly from our patients just kind of raised the visibility and urgency of addressing that issue in a different way. You know, as opposed to it just being, oh yeah, we know our patients struggle with food and, some of them do, but seeing it, I think, on paper, and sometimes the numbers are just higher than people expect. And so I think it can be very powerful data for motivating people to take action.
Yeah, Sue, this is Gina. I will say that I do know that Kaiser has piloted a type of a screening that is collecting more of this kind of social determinants of health data and more kind of, I forget what they're calling it, but kind of, life data.
Yeah.
I don't know that if that data is contributing or being incorporated into their CHNA. It may be incorporated. They're in the process right now of doing their next round of the analysis. So I don't know if maybe they will be pulling that and including that with their upcoming analysis and report. I also do know that some of the FQHCs are also using some screening tools that are capturing some of this kind of data. In fact, one of our partners, Communicare in West Sacramento, does have kind of a social determinants of health screen that they've started piloting. But again, I don't know how routinely they're collecting that data and using that data in the aggregate form.
That's great to hear. Yeah, chances, if it's a community health center, I wouldn't be surprised if they were doing Prepare or some kind of derivative of Prepare, because that's pretty typical.
Heather.
Kaiser would be an interesting.
Sorry, go ahead.
No, I'm just, yeah, go ahead.
Well, Heather, I don't know if, I know you're in a noisy spot, but she's just been putting stuff in the chat. So I don't know, Heather,
oh, I see.
Talk just about her partnership with Kaiser. Heather, can you talk, or is it too noisy? I don't know if you want to put it in the chat.
Yeah, I can try, but sometimes it's pretty loud here. Yeah, just as I said in the chat, we've been contacted by Kaiser Permanente to help them do some focus groups for their community needs assessment, and they're specifically looking at housing. That's a critical issue, of course, across the state of California, but certainly in Los Angeles and the densely populated East Side where we operate out of. So that's really a focal area, but I know they're looking at the social determinants more generally, but housing was the one that kind of elevated up that they want to really dig in on. So we'll be helping them on that. And then medical center that we work with, the LAC USC Medical Center, they've been working just really, I think, in the last year to incorporate more social determinants questions as part of the screening process for patients in primary care. So that's, I know, one of their new initiatives. It doesn't really speak to the community, needs assessment, but it is starting to just move the ball on that and really starting to track what's coming through the patient population that they see.
Great. Thanks, Heather. Yeah, interesting.
So that's
I'm curious to hear kind of if there are other ways that all of you or any of you are kind of partnering with health systems that are working on social determinants of health. Just curious if kind of, the suggestions I made, do those seem like ones that can be used? Do they, are there others that you're finding to be more helpful? Curious what your all experiences have been.
Yeah, I don't know, like Humboldt, if you have any comments, Catherine, I don't know if Catherine Johnson, if you want to add anything as well, any thoughts? But
no, I mean, we're just trying to figure out how to get the data. And, I think the work that Carolyn's really focused on, which is really great, is, what happens when the data is gathered and how is the healthcare community integrating the data into the delivery of care. And yeah, I certainly am not in my work with the HIEs. We're just trying to identify. But I do think that, figuring out the assessment tools and how they can be leveraged at the point of care, and frankly, which ones, right? There's so many different ones. That's also an area that we're interested in. Carolyn, I did actually have a chance to connect with Rishi in addition to being at the All In conference. That's Rishi of Health Begins. With those of you that were in the All In conference, remember him speak. But one of the things that I thought he suggested, which was really interesting, was kind of backtracking. So if the question is, how do we collect the social determinants of health data? And we use the assessment tools as one of them, and then, as a mechanism to collect the data, but we recognize there's a lot of assessment tools, and how do we determine which assessment tools we're going to invest in from a data collection perspective, you know, he said, and, you know, I thought it was a really interesting comment, you know, the EHR vendors are always the tail wagging the dog, right? Or the tail wagging the dog. And so his comment was, you know, ultimately we know that we want the data to get into the EHR, and it's always the challenge is it's challenging getting it into the EHR. So if we look at the assessment tools that are being integrated into the EHR, knowing that ultimately that's going to be the path of least resistance, then it was kind of an interesting approach. You know, it's backing into it. So, you know, that's one of the things I'm going to be looking at is, you know, what is Epic doing and Cerner, and, you know, you might already know that, Carolyn. Do you know?
They're all doing a fair amount. I don't know the details. I just know that I hear bits and pieces here and there. Epic has a whole social determinants of health working group, and they've been developing a whole way of visual, you know, like a place in the EHR where that data would be represented in a particular way, et cetera. I know that Cerner's been doing a certain amount of work in this area as well. So I think that they're all doing something in terms of which tool they're looking at. I know that, so one of the set of tools that are in this, it's not really a tool, but there was a National Academy of, well, when it used to be called the IOM in 2014 put out a report that identified domains that should social, behavioral, domains to have that should be collected in the EHR. So a lot of the oh, sorry, can you guys not hear me?
No, I can hear you.
I can.
Oh, sorry. Okay. And so a lot of the EHRs have started there. The challenge with that is that the domains recommended by that report for things related to basic needs was just basically one question around financial strain. And so it doesn't necessarily match what most people are doing in practice, which is they're looking at housing specifically and food and transportation. So they're going deeper than just financial strain overall. So I think that then the EHR companies are realizing that and incorporating others. I wouldn't be surprised if they're doing the AHC one and Prepare as the two that they've kind of focused on, just because they're so widely used. But that'd be a good place to look for sure.
Yeah, I mean, I think that's a way that some standardization is going to happen, whether we agree with it or not, right? I mean, that's the way it seems to happen.
I'm wondering, the folks in Humboldt, do you have any comments or reflections that you want to add?
Hi, this is Martin. None of the provider organizations in Humboldt that sort of qualify as systems are collecting significant determinants data. It does get discussed a lot, and apparently people have some plans, but it's not happening at that level.
Is Partnership Health Plan up where you are?
They are.
Because I think they're doing a fair amount, but I don't know if they're requiring any data collection as part of it. I know they've instituted a new transportation benefit that I was just talking to some health centers in Sonoma County where really, we're using that a fair amount.
It's certainly possible. I haven't heard that.
Okay. They'd be an interesting, set of folks to talk to potentially if you are interested in exploring partners in the healthcare world. I know that they've, I've seen them at a number of meetings and they seem interested in particular in social determinants issues. I know they funded several efforts maybe a couple years ago around, I want to say homelessness and maybe
Lake County, Lake County applied for, they got like $1 million for a housing project. So Gina, I don't know if you can speak. So she said they're in our West Sac ACH and they have begun transportation services working through Access. So I agree. I know that they're in a number of the sites and have a pretty, like they're participating pretty intentionally. So I think it's something to explore. I know they're very interested in metrics and quality improvement and all of that. So yeah.
Great to hear.
Yeah. One thing that you spoke about at the All In conference that I didn't hear you speak to today that I thought was really interesting, and it was kind of there, but just digging deeper, is just that study that was done of providers' perspectives once they started doing the screenings. I don't know if you could speak to that, because I think it's really important.
Yeah, there's been a couple of studies, and the one that I cited at All In was one of those, but that was most recent. And in that particular one, so they asked providers how having social needs data affected the care that they provided, and over half of the providers said that I'm not going to remember the exact details, but it definitely affected how they interacted with their patients in terms of having a better sense of their patients' experiences and what their needs were. And we're seeing this, I think, anecdotally also a lot in the conversations that we're having with different settings that are implementing this, that it goes back a little bit to the point that I was making earlier, that oftentimes it just presses home to people the needs that exist. And then it just gives providers and other members of the care team just a better sense of where patients are coming from, what the challenges they have are. I think it's always been clear, obviously, that if a patient is homeless, the kinds of ways in which they can care for themselves are going to be different than people who are housed. But I think understanding that food insecurity has impact, that general financial strain has impact. People are really, if they're really struggling with transportation issues, or if childcare is really getting in the way of them being able to work as much as they would want, all those things then lead to a better understanding of what kinds of medical advice will be helpful, and also potentially in kind of how to what to recommend in terms of treatment, et cetera. So we are seeing evidence of that start to accumulate.
Great, thank you. I think it's important. Yeah. Any reflections or at all? I do think this piece, it's something to kind of keep watching, is the use of that data. And again, I just want to go back to like community health assessments and how, just because of one of the other projects that I'm on around community benefit, and how that data could really be useful in terms of resource allocations and where resources are being allocated or not. I think it's just another kind of data point that figuring out how to actually, get it and have it be part of the picture is going to be really important, as well as probably other uses. So I appreciate that. Okay, well, any other comments, thoughts, reflections? We don't, I don't know what time it is, but I don't think it's noon. We can give you a couple minutes back in your day. Okay, well, great. Well, I'm most appreciative. I think it's very exciting work. And like I said, I will post this information. And I look forward to more engagement around this, because I think it's pretty exciting.
Great. Well, thanks so much for giving me the opportunity. And if anybody has any questions about any of our resources or anything I presented, don't hesitate to get in touch.
Great.
Thanks so much. Have a great afternoon, everyone.
Thank you.
Bye.
Okay, thanks. Bye, guys.
Bye.